All right, guys. Today we're going to cover part 2 of the pharmacokinetics lecture. So we're talking about pharmacokinetics, which remember includes the principles of ADME: absorption, distribution, metabolism, and excretion. We're talking about distribution. So distribution is when the drug gets distributed out to the tissues. So the drug got absorbed into the bloodstream, and now it's going to get distributed to the tissues. So distribution is when the drug reversibly leaves the blood and enters the tissues or extracellular fluid. So distribution, right, where the drug is distributed to and how fast and how much is distributed depends on local blood flow, capillary permeability, protein binding, both to plasma proteins in the blood and tissue proteins in our tissues, and the lipophilicity of the drug. So we'll talk about each of these. We'll start with local blood flow. How much blood flow is happening in a tissue influences the drug being distributed into that tissue or not. When we look at blood flow to different areas, we see that the brain, the liver, and the kidney get the most blood flow, then the muscles, then the fat, skin, and viscera. So that means that when we have a drug flowing through the bloodstream, that drug is most likely going to get distributed most to the brain, liver, and kidney, right? Assuming it's permeable in those areas. So for example, let's talk about this drug, propofol. Propofol is an anesthetic, right? This is a drug we use for anesthesia, to put patients out for anesthesia. When we give this drug, when it enters the bloodstream, it very rapidly distributes into the central nervous system because there's a lot of blood flow going to the brain. It also happens to be very lipophilic, right? It likes lipids, so it can cross the blood-brain barrier very easily. So because there's a lot of blood flow to the brain and it can easily cross barriers, it enters into the brain really quickly, producing anesthesia. It has slower distribution into the muscles and adipose because they don't have as much blood flow. So initially, there's a bunch going to the brain and the patient is anesthetized. They lose consciousness. But then over time, the drug slowly leaves the blood and gets distributed into the other tissues, which lowers the plasma concentration and then pulls propofol out of the central nervous system, right? Because we're talking about concentration gradients. So as we decrease the amount in the blood, it ends up getting pulled back out of the CNS and the patient regains consciousness. So blood flow influences where the drug is going to distribute, how much of it's going to distribute there, and when it's going to distribute. Capillary permeability also matters. Capillaries in different parts of the body vary in their permeability. Remember, we have different types of capillaries. We have just our normal continuous capillaries. We have fenestrated capillaries that are more permeable. And then we have sinusoids that are very, very permeable. So, for example, the bone marrow, the liver, and the spleen have sinusoids. There are actual slit junctions or gaps between endothelial cells. So they are very, very permeable. That means most drugs will be able to distribute into these tissues. That's why, like, the liver can metabolize most drugs, because most drugs are able to exit the blood and go into the liver. Very permeable. The opposite is true about the capillaries in the brain and thymus. When we look at the continuous capillaries that are in the brain and thymus, they have actual tight junctions between endothelial cells. So the endothelial cells that line the blood vessels there are tightly attached to each other, meaning it's very hard for things to cross, from the blood and distribute into the tissues. So if a drug is going to cross the capillaries and go into the brain, it has to be lipophilic, right? So lipophilic drugs can go straight through the endothelial cells, plasma membrane, and they can distribute into the brain just fine because there's a lot of blood flow there. But if you have a drug that's hydrophilic, right, if you have a drug that does not like lipids, it will not distribute well into the brain because it can't leave those capillaries. Now, there are a couple kind of caveats, a couple things that come into play here. When we're talking about whether a drug can distribute into a tissue, and we're talking about capillary permeability, we design drugs very purposely in order for them to distribute to certain areas. When we're talking about drug design, we look at the size of the drug. So the smaller the drug is, the easier it'll cross through membranes. We look at lipophilicity. We've already mentioned the more lipophilic, the easier it'll cross through capillary walls and distribute. Also, drugs can use transporters to get across capillary walls. For example, levodopa. Levodopa is a drug that we use for Parkinson's disease, and it has to work in the brain. It doesn't actually cross the endothelial cells membranes, but levodopa is made to take advantage of a transporter that's present. So the transporter pumps it from the blood and into the brain. When we talk about a drug distributing into the tissues, we said that protein binding matters, and we have to consider plasma proteins as well as tissue proteins. So just in general, remember, we just said that drug size matters, right? Drugs have to be small enough to be able to cross capillary walls. If a drug is huge, it can't cross a capillary wall. So plasma protein binding matters. Some drugs bind to plasma proteins. When the drug is binding to that plasma protein, it's huge. It's too big to leave the blood. So what happens is, like say this is my blood, right? And this is my drug. And these are my plasma proteins. So all of the drug that's bound to the plasma protein, it's stuck in the blood. It can't leave. Now, this drug that's free, that's not bound, it can leave and go work on its target. But the drug that has a plasma protein is essentially stuck in the blood. It can't go do anything. So the plasma protein binding creates a reservoir of drug in the plasma that slowly gets, released to work, because there's an equilibrium between the amount of drug that's bound and the amount of drug that's free. So say this is the equilibrium, right? 2 drugs are free, 4 are bound. Well, if these drugs right here leave and go work on their target, I've messed up that equilibrium. So that means some of this drug that was bound will go ahead and lose its plasma protein. It'll detach. Well, then that's free and it can go work. Then I messed up my equilibrium. So some of this drug will get rid of its protein and be free. And it can work, right? So like you have this bank account of drug that's bound to plasma protein, and slowly it gets released and it can go work on a target. So those drugs that are bound to plasma proteins, they work for a long period of time. Albumin is a common plasma protein that binds to drugs. And that's important to keep in mind, because if a patient's taking a drug that's highly plasma protein bound, and then you find out that maybe this patient is going into, liver failure or something, and they have really low albumin, well, that's going to affect the drug, right? All of a sudden, they're going to have much more free drug than they had before because their albumin is low. There are some drug interactions that occur because of plasma proteins. For example, you can have 2 drugs that are competing for plasma proteins, and that's what this example here is describing. If I have my blood here and I have here are my drugs, and these drugs are binding to, these plasma proteins. If I have a patient who's stable on warfarin, which is binding to proteins, right? That's what this picture is right here. This is warfarin. Some of the warfarin is able, to go leave and work, but a lot of it's bound to plasma proteins. Well, now say I start this patient on another drug, say valproic acid, which is also going to bind to proteins. Well, now this valproic acid is actually going to steal those plasma proteins from the warfarin. And now all of this warfarin here, this warfarin is no longer going to be bound to a protein. This warfarin is no longer going to be bound to a protein. So he's going to have much more warfarin that's available to go work because you only have so many plasma proteins, right? Say I have 20 plasma proteins and warfarin's binding to all of them. Well, now I give valproic acid, and valproic acid is going to have to use half of those. Now there's only 10 proteins available for warfarin. So that means that the other half of the warfarin is now going to be free. So it's going to be able to go leave the blood and work on its target, which warfarin actually works in the bloodstream, but it's going to be able to work on its target. So you would have a much greater effect from the warfarin now that you added valproic acid. Now those drugs also happen to interact with each other with CYP enzymes. For example, valproic acid inhibits CYP2C9, which is the drug that metabolizes warfarin. So they interact on multiple levels. Drugs can also bind to tissue proteins. And this is problematic because this can end up causing, extra toxicities in tissues. Or it can cause drugs to accumulate in a tissue and prolong their effect. So it's kind of the same reason, right? So I have my blood, right? And I have my drug. And then over here I have my tissue, right? These are my cells. And the drug leaves the blood and it comes over here and it's going to work on my tissues. Well, once the drug leaves the blood and works on my tissues, it eventually, right, is going to go back into the bloodstream and get carried away. But if I have tissue proteins out here and those tissue proteins bind to the drug, now that drug is too big to enter the bloodstream and get carried away. It's never going to be able to leave. It's going to be stuck in the tissue, right? As long as the tissue proteins are holding onto that drug, we're not going to be able to take it away and clear it from the body. So that means that the drug is going to be concentrated there in that tissue, and that can cause local toxicity. For example, cyclophosphamide. Cyclophosphamide is an anti-cancer drug, and like most anti-cancer drugs, it can cause cell death. It causes toxicity to drugs. Cyclophosphamide happens to accumulate in the bladder because it binds to tissue proteins in the bladder. And then you have this toxic drug that's stuck in the bladder that ends up eating away at the lining of the bladder. And it causes hemorrhagic cystitis, right? Inflammation of the bladder, hemorrhagic, that ends up bleeding because you're eating away at the wall of the bladder. Other things that affect the distribution of drugs include the lipophilicity of the drug. I already mentioned this a couple times, but lipophilic drugs easily cross membranes and they can distribute quickly no matter what type of capillary is there. So when you have a drug that's lipophilic and you're trying to figure out how it's going to distribute, the major factor is going to be blood flow. That means it's going to distribute to areas like the brain, the kidneys, faster than other areas because those areas have a lot of blood flow. Okay, so we're going to talk about volume of distribution. Just bear with me, it does have clinical implications, but it's theoretical in the beginning. So the volume of distribution is the theoretical volume that describes the volume of fluid that's needed to account for the total amount of drug in the body at a specific plasma concentration. So once the drug enters into your body, it can go into any of the three compartments: the blood, the interstitial fluid, or the intracellular fluid. Where it goes depends on properties of the drug, right? What kind of membranes can it cross? How big is it, etc. But what the volume of distribution tells us is, imagine if it distributed instantly, right? It takes time for the drug to leave the blood and go into its compartments. But if it distributed instantly, how much fluid would that drug be in? So if the number is really small, that means that it probably never left the bloodstream. If the volume of distribution is really big, then you need a lot of body fluid to account for all of the drug, right? It went to a ton of different places, so it probably distributes into the tissues. Okay, let me explain. So here are the three places that the drug can go, right? In the blood, in the extracellular fluid, or intracellular fluid. Drugs that are large or highly protein bound are trapped in the blood. Right? They can't leave the bloodstream. So they have a volume of distribution close to the total volume of the blood, right? They don't leave the blood. So the amount of volume that they're in when they distribute is just the blood. They never left. For example, heparin has a volume of distribution that's very close. It's 4 liters, very close to the liter, the amount of blood that we have. Oh, sorry. And when we talk about like how much blood we have, about 60% of your body weight is water. So like you have a lot of water in your body. If you were talking about like total body weight, right? So like 70 kilogram person, if 60% of their body is water, 6 times 7 is 42. So that's 42 liters of water total. So that means that like total between your blood, your extracellular fluid, and your intracellular fluid, you've got 42 liters total. So 4 liters is pretty small. That means the drug's not going into much of that fluid. It's just staying in the blood. Extracellular fluid. So drugs that are small, so they can kind of cross membranes, but they're hydrophilic. They can leave the capillaries to get into the interstitial fluid, but they can't cross the actual cell membranes to get inside cells. So they remain in the extracellular fluid, and they have a volume of distribution close to all extracellular fluids. So this is like around 14 liters. Okay, so aminoglycoside antibiotics like, for example, gentamicin or amikacin, they have volumes of distribution that's close to this. Drugs that are small and that have enough lipophilicity to enter cells have a big volume of distribution, right? Close to total body water. So like alcohol, for example, can go into our cells. It distributes everywhere. It can enter all body fluids. So it has a big volume of distribution. Again, the point here is a larger volume of distribution indicates greater distribution into the tissues. Smaller volume of distribution indicates that the drug is confined into the plasma. It doesn't leave the blood. Now, we can calculate the volume of distribution for a drug. So what we do is we say volume of distribution equals the dose that we give divided by the concentration, that's like the concentration of the drug immediately when it's given. That's what, C sub 0 is concentration when the time is time 0. No time has gone by. Immediately when you inject the drug, what's the volume of distribution? Now, we can't just like draw blood from the patient and say what that volume of distribution is, because it takes time for distribution to occur, right? When we plot the log of the drug concentration over time, right? Like here's the concentration, here's time. And the drug concentration is really high when we first give it, and then it slowly leaves the bloodstream, and the concentration slowly goes down as it leaves the bloodstream and distributes. And then we'll see that it kind of like adjusts a little bit, and then it slowly goes down as we eliminate it from the body. So what we have to do to extrapolate, you know, the time if it were to distribute immediately is to just draw a straight line back like that. And this is the concentration if distribution happened immediately. I'll show you a graph on the next slide. So if we give 10 milligrams injected, and the concentration, if distribution was immediate, would be 1 milligram per liter, right? So 10 milligrams divided by 1 milligram per liter equals 10 liters. So the volume of distribution is 10 liters. That means that some of the drug leaves the bloodstream and goes into the tissues, but it does not go into the cells. That's still a relatively small volume of distribution, but the drug is probably, you know, small enough to leave the bloodstream and distribute a little bit into the interstitial fluid. This is how we figure out the concentration at 0 time. And when we're trying to figure out volume of distribution. So again, right here is when we injected the drug. But it takes time for the drug to distribute into the tissues. This is the distribution phase right here. This is when the concentration in the blood is going down, but it's not because we're clearing it from the body. It's because it's leaving the bloodstream to go out into our tissues. That's the distribution phase. Then we see it's done distributing, and the drug goes down, the concentration goes down from there because we're eliminating it from the body. We're putting it into the urine and we're metabolizing it, and that's why the concentration goes down in the elimination phase. So we need to take this line for the elimination phase and extrapolate that back to T equals 0. That gives us the concentration in the blood if distribution happened immediately. Now, volume of distribution is important because it influences the half-life of the drug. So, like, how long is the drug going to be present in our body is influenced by the volume of distribution. So the half-life is defined as the time it takes for the concentration to decrease by half. So if the serum concentration was 40 milligrams per liter, how long does it take to go down to 20 milligrams per liter? That would be the half-life, the amount of time it took for that to go down by half. Now, drugs must be in the plasma in order to be cleared from the body, right? If a drug is in my subcutaneous tissue, I can't clear it. It's not going to come in contact with the liver or kidney to be cleared. So drugs have to be in the blood in order to be delivered to the liver or kidney for elimination. So if a drug has a small volume of distribution, that means that all of the drug is in the blood and it's really easy to clear it from the body. But if the drug has a large volume of distribution, it's spread throughout my body. That means a lot of it is protected from being cleared. It's not going to get cleared from my body until it goes back into the bloodstream. So that means anything that increases volume of distribution increases the half-life and extends the duration of action of my drug. Okay, so let's talk more about half-life. We said that the half-life of the drug, or sometimes you write T1/2, the half-life is the time that it takes to decrease the plasma concentration by half. The longer the half-life, the longer the drug's duration of action. This makes sense. The longer the half-life, that means the longer it takes for us to get rid of the drug, the longer it's going to be available in the body, which means the longer it can work. So let's look at this and figure out what's this drug's half-life. So first off, this is time, right? It's marked in hours, and this is blood concentration over here. It looks like they took this by mouth because here you see the concentration slowly increasing as they're absorbing it, and concentration goes all the way up to 40, right? So here it's at 40. Half of 40 is 20. So I want to see how long does it take to go from 40 to 20? Well, 40 is at 1 hour, and then here's 20, right? 20, it went down to 20 milligrams at 2 hours. So it took 1 hour for that to happen. Let's just double check ourselves. Half of 20 is 10, right? So how long did it take to go from 20 to 10? Well, it was at 20 milligrams here at hour 2. It's 10 milligrams here at hour 3. So it took from 2 to 3, it took 1 hour to go in half. That's the half-life. You can see here that the drug decreases by half every 1 hour. Now, clearance of the drug from the body can occur, right, that's distribution, right? That was distribution. It distributes into the tissues. It requires a certain amount of volume to distribute into the tissues, and how long it takes to get rid of it is related to half-life and duration of action. So when we talk about half-life, how long the drug is going to be available, we're talking about its clearance from the body. So clearance of a drug from the body can occur via 2 different pathways. Clearing the drug from the body can occur via metabolism or elimination, right? So these are our last 2 things with ADME. Absorption we talked about, distribution we talked about. Now we're going to talk about metabolism and elimination. So metabolism occurs when we biotransform the parent drug into its metabolites. So we have this drug that we took. Our body is going to perform chemical reactions on it to convert it into metabolites. Now, the reason our body does this is because we want to make it easier to get rid of the drug. So the metabolites are more polar to allow for elimination. We want them to be polar so that we can eliminate them. And then elimination is the actual removal of the drug from the body. And that's what we talked about in part 3. So clearance estimates the volume of blood that is cleared of drug per unit in time. So we can calculate clearance by doing 0.693, which is a constant, times the volume of distribution over the half-life. And again, this will tell us what amount of blood are we able to clear out in a certain amount of time. Now, we're going to talk a little bit more about metabolism. So the metabolism of drugs is catalyzed by enzymes. We have numerous enzymes that are used in order to perform chemical reactions on drugs so that we can convert the active drug into its metabolite. Most of the time, these reactions obey what's called Michaelis-Menten kinetics. Okay? When we talk about Michaelis-Menten kinetics, Km is the Michaelis constant. Okay, so this doesn't change. Km is the constant, and the formula that we use is right here. So V is the rate of metabolism. So we're calculating the rate of metabolism of the drug, right? The rate of metabolism equals V max, the maximum that you could possibly metabolize, times the concentration of the drug. And that's all of that is divided by the Michaelis constant plus the concentration of the drug. So you can see that the concentration of the drug is both in the numerator and the denominator, right? But we're multiplying up top, we're adding on the bottom. So I don't know if you guys actually want to know, Km, like the constant, is the concentration of the drug at half of the maximum velocity of metabolism. So that just means like the concentration of the drug when you're using half of your enzymes. You don't need to know that though. So this is like the base formula. We're going to take that formula and alter it to kind of fit 2 different situations. First order kinetics and zero order kinetics. So first order kinetics or linear kinetics. This is more common. Most drugs obey first order kinetics. Okay, so when we look at first order kinetics, usually this Km is way bigger than the actual concentration of the drug. Okay, because again, Km is talking about, that's related to like how much of the drug you could possibly metabolize. Usually you have a ton of enzymes. You could metabolize way more of the drug than you actually have. So the actual concentration in your body is like way less than Km. So when that's the case, if you look at this formula up here, if Km is way bigger than the concentration, you can just get rid of the concentration on the bottom. Doesn't matter. It's like adding a drop of water to the ocean. It just doesn't matter. So that means the formula becomes this, right? You're metabolizing the maximum rate of metabolism times the concentration, right, over this constant. That means that the rate of metabolism, right, V, the rate of metabolism, is proportional to the concentration of the drug, right? So the more drug you have, the more you're going to metabolize. The less drug you have, the less you're going to metabolize, right? This is what I want you to take away from this. For most drugs, the more drug you have, the more you metabolize. The less drug you have, the less you metabolize. So a constant fraction of the drug is metabolized per unit in time, not a constant amount, right? So this is why each half-life, half of the drug is metabolized. Remember on that last slide that we looked at? Like in 1 hour, the first hour, we metabolized 20 milligrams. The second hour, we only metabolized 10 milligrams. The third hour, we're only going to metabolize 5 milligrams because a constant fraction is metabolized per hour, not a constant amount, right? Every half-life, half of the drug is metabolized. Because if you look at our equation here for first order kinetics, right, the rate of metabolism is proportionate to the amount of drug. As we have less and less drug, we metabolize less and less at a time. That's how most drugs behave. Now, zero order kinetics is nonlinear kinetics. Zero order kinetics occurs when the doses of the drug are so large that the concentration is much greater than Km. So in this case, right, like it doesn't matter it doesn't matter how many enzymes we have available. Like the concentration of drug is so high that we're using all of them. Like we are already metabolizing the drug as fast as we possibly could. And in this case, because remember, the rate of metabolism is V max times concentration over concentration plus Km. Well, we said Km doesn't matter because it's so small. It's a drop in the ocean compared to the concentration. So we're left with this formula. Well, we have concentration on top and concentration on the bottom, so that can get crossed out. This means the rate of metabolism is equal to the maximum rate of metabolism. I am metabolizing this drug as much as I possibly can. So the rate of metabolism remains constant over time. It doesn't matter what the drug concentration is. That means that a constant amount of the drug is metabolized per unit in time, not a constant fraction. So for these drugs, it's not 50% every hour. It's an amount, like 10 milligrams per hour, period. Because you're using up all your enzymes and you're doing it as fast as you can. So it's not a fraction. This is not as common, but drugs like aspirin, ethanol, phenytoin are exhibit zero-order kinetics. These drugs tend to build up over time because as you take more and more and more, it just builds up higher and higher and higher, and you're not able to metabolize more and more and more. These graphs show you the examples of each of these. So zero-order kinetics and first-order kinetics. Notice this is showing you the rate of metabolism, so how fast you metabolize, and then on the bottom, the concentration. So for zero order, you metabolize the same no matter what, right? So as the concentration goes up, as you have more and more and more drug, the metabolism stays the same. I can't metabolize anymore. It is what it is. But with first order kinetics, as the concentration goes up, my rate of metabolism goes up. So the more drug I have, the more I metabolize. So we'll talk about the specific reactions that we utilize for metabolism. In general, metabolism is converting a lipophilic drug into a substance that's more polar. And again, the reason for that is the kidney can't excrete lipophilic drugs. Lipophilic drugs cross membranes. So the kidney will excrete it into the urine, but then it just crosses the membrane to get reabsorbed again. And it just cycles through and it keeps getting reabsorbed. If the drug is more polar and water soluble, the kidney can excrete it into the tubule and it stays. It stays in the urine, so we can actually get rid of it. Now, there are a couple different types of reactions. Again, phase 1 reactions, phase 2 reactions. Phase 1 reactions introduce or unmask polar groups. So this might be a reaction that adds like an OH, a hydroxyl group, or it might add nitrogen or something, an amino group with nitrogen. Now, this can increase, decrease, or have no effect on pharmacologic activity. Sometimes we give drugs that are not active when we give them, and they actually have to be metabolized in order to be activated. Those are called prodrugs, but most drugs aren't like that. Most of these phase 1 reactions utilize the CYP enzymes. Cytochrome P450 enzymes are what we call CYP enzymes. Phase 2 reactions involve conjugation, so like joining the drug with some sort of endogenous substance, so with some sort of thing that's already in the body. So like sometimes we do what's called glucuronidation, where the drug gets joined up with glucuronic acid, or it could get joined with acetic acid or sulfuric acid, an amino acid. It doesn't matter. The drug gets conjugated with another substance that was already in the body. Again, this makes the drug or the metabolite more water soluble and more excretable. This almost always produces inactive compounds. The one caveat here is morphine. The glucuronidation of morphine, which is a pain medication, an opioid pain medication, produces morphine 6-glucuronide, which is actually more active. So when morphine gets metabolized, it gets metabolized to a more active compound. Now, drugs don't have to go through both. Like, not all drugs have to go through phase 1 and then phase 2 reactions. Some just do one, some do both. It's both are possible. Now, these phase 1 reactions we said are catalyzed or sped up by the cytochrome P450 enzymes, or we call them CYP enzymes. Now, cytochrome is a superfamily of enzymes that are really heavily concentrated in the liver. When we look at the CYP enzymes, you'll see CYP, that's telling you it's the cytochrome family of enzymes, and then you'll see that there is additional information after that. So like CYP3A4, for example, the number tells you the family, and then the subfamily, and then the specific isoenzyme. There are a lot of CYP enzymes. CYP enzymes exhibit specificity, right? So we have a lot of different CYP enzymes because we have to metabolize a lot of different compounds. Sometimes drugs are substrates for multiple CYP enzymes. So you could have a drug that's metabolized by numerous different enzymes. The enzymes that you see here are responsible for most drug metabolism. So CYP3A4, 2D6, 2C9, 1A2, 2C19 is another one. CYP2C19 is also involved with a lot of drug metabolism. Now, the CYP enzymes exhibit some genetic variability between people and between racial groups. So not all CYP enzymes are created equal, and this is important because this can affect how patients respond to drugs. Patients can be poor metabolizers for a specific CYP enzyme. So that means that that specific enzyme does not work well in them. Now this is problematic because if the enzyme can't metabolize the drug builds up, and patients will be more prone to drug accumulation and adverse drug effects. Keep in mind, though, this would not be the case with prodrugs. Prodrugs are drugs that are activated, right, by the CYP enzymes. These are drugs that are not active until a CYP enzyme activates them. I'll talk about one down here. Clopidogrel is an example. So those drugs would actually be activated faster, those drugs would actually not be activated in poor metabolizers. So if you gave a prodrug to a poor metabolizer, the drug wouldn't work. So it wouldn't build up and cause adverse effects, but it wouldn't work. Rapid metabolizers have very, very good working enzymes. The enzymes work like crazy. Now, the drug's not going to build up and hurt them, but it does mean that the drug won't work. So if you give a patient a drug and you just can't figure out why it's not doing any good, they might be a rapid metabolizer. CYP2D6 is an example that exhibits a lot of genetic polymorphism. CYP2D6, I think I have this on the next slide. CYP2D6 polymorphisms are very common in East Asian patients, but again, I think I have it on the next slide. Some clinical examples. So the opioid analgesic codeine, right? So this is a drug that provides pain relief. Codeine is a prodrug. It requires the activation by CYP2D6 in order to work. What would the outcome be if a patient is a CYP2D6 poor metabolizer? That means that you could give the patient codeine and it would not work for them, right? The patient would not get pain relief from that codeine. The antiplatelet drug clopidogrel. This is generic Plavix. Again, it's antiplatelet. It helps to prevent clots. This is a prodrug that's activated by 2C19. Patients who are poor metabolizers will have a diminished response. Now, this is especially problematic. With the codeine, at least you know it's not working, right? The patient's experiencing pain. They can tell you it's not working and you can try a different drug. With clopidogrel, you don't know that it's not working. The patient can't feel it. The way that you know it didn't work is because the patient ends up having a clot, which can be possibly fatal. That's very dangerous. Now, there are some drugs that act as CYP inducers and CYP inhibitors. So there are some drugs that will actually make CYP enzymes work more, or will actually stop the CYP enzymes from working. CYP inducers increase the activity of specific CYP enzymes, which increases how they metabolize other drugs. For example, phenobarbital, rifampin, and carbamazepine are all drugs that induce CYP2C9 and CYP3A4 and 5. Phenobarbital and carbamazepine are both drugs that are used for seizures. Rifampin is an anti-tuberculosis drug. Um, let's see, there are no known inducers for CYP2D6. Just kind of FYI, there are a lot of inducers for 2C9 and 3A4, but we don't know any for 2D6. CYP inhibitors are drugs that inhibit the activity of some specific CYP enzymes, which reduces the metabolism from those drugs. So if you give a patient an inducer, if you give a patient an inhibitor, that's going to cause increased concentrations of drugs and increase the risk of toxic effects. Erythromycin, ketoconazole, and ritonavir all cause inhibition of several enzymes. Erythromycin is an antibiotic. Ketoconazole is an antifungal drug. Ritonavir is an HIV drug. So let's look at a clinical example here. Omeprazole. Omeprazole is a drug for acid reflux. Inhibits the metabolism of warfarin. When omeprazole is added, plasma concentrations of warfarin increase. What's the risk? Well, warfarin is a blood thinner. So if we have increased concentrations of warfarin, we're going to have an increased effect, right? The patient might bleed too much. With ritonavir, so ritonavir is an HIV medication that inhibits CYP enzymes. We actually give this intentionally. So we combine ritonavir with some other HIV meds to try and increase the concentration of the other HIV meds. So the ritonavir itself is not very effective, but it inhibits enzymes so that we can have the other drugs around longer and make them more effective. Okay, let's see if we can get through these questions in the last 3 minutes that I have. KEGAR2250 is an investigational new drug with a small molecular weight and extensive protein binding to albumin. It will have a blank volume of distribution. Well, if it is small, I was starting to think, okay, it'll leave the blood, but it has extensive protein binding. The protein binding holds it in the plasma, so it's going to be stuck in the blood, which means it will have a low volume of distribution. The drug from the previous example is given to a patient with severe liver failure. What, if any, change in the volume of distribution will there be? Well, the reason the volume of distribution was small was because the drug was bound to albumin and stuck in the blood. If the patient has severe liver failure, they don't have enough albumin, right? We make plasma proteins in the liver, so they won't have enough plasma proteins. So that means a lot more of the drug will be free to leave the bloodstream. That means that the volume of distribution will go up. More of the drug will leave the bloodstream, which means the drug will be around in the body longer. Last one. A 68-year-old woman is brought to the emergency room for a myocardial infarction. So they're having a heart attack. She's taking clopidogrel, an antiplatelet drug, and aspirin daily to try and prevent heart attacks and strokes, as well as omeprazole for heartburn. Omeprazole is a potent CYP inhibitor. Which of the following is a likely contributor to her heart attack today? Well, we mentioned this. You guys know that clopidogrel is a prodrug. It has to be activated by CYP enzymes in order to work. Here we're saying omeprazole is an inhibitor. So omeprazole is preventing the activation of clopidogrel, leading to this patient's myocardial infarction. Reduced antiplatelet activity of clopidogrel due to aspirin? No, aspirin actually helps with that. Hypersensitivity reaction? No, nothing here indicates a hypersensitivity. Reduced antiplatelet activity of clopidogrel due to omeprazole? Yes, that would be the answer. Increased antiplatelet activity? Well, no. I mean, if the antiplatelet activity were increased, then it wouldn't have failed for us. Okay, guys, I just made it with like 15 seconds to spare. If you have any questions, go ahead and shoot me an email. Otherwise, thanks for watching.